Hi guys, good evening, good evening. So, can you all hear me? Can you all see me? Walaikum assalam. Hi Mansoor. Hi Rahul. Hi Yakeen. Right, so I think audio video is check. So, we are nearing our first season of your BLS, that is the series that we have started. So we started with the basic concepts of thyroid and then we continue to build. So this is the last topic that will be there in the BLS season 1, that is going to be your thyroid surgeries. Okay? Don't worry, the BLS season 2 is from next week only. So we are going to keep it season by season. So the next week we'll be starting with something really important and amazing. I will announce it once we are done with our season 1. Good evening, Osama. Hi, good evening. Hi, madam. All right, so your ortho faculty is also tuned in. Shout out to her as well. Srishta Dasari. Hi, good evening. Good evening. Right, so without wasting any further time, let's begin. All right, so we'll start with the thyroid cancer and then we'll build up from there onwards. Okay. Now, when we talk about the malignancy has to arise from any of these components which are going to be present. So what we are going to say that either the malignancy is going to arise from follicle. If it is arising from follicle, we'll be calling it as follicular origin. We'll be calling it as follicular origin. On the other hand, Harish Kumar, NEET 2025 student. Hi Adya. If you can see me. Right. Okay. Can you please talk in English? I think I am speaking in English. I don't know any other language like Greek, Latin, or any other stuff. So concentrate, hear well. Probably the words coming out from mouth are sounding in English only. Okay, right. So if the tumor is originating from these, it is going to call as follicular origin. If they are going to originate from this, we'll be call it as the parafollicular in origin. In parafollicular in origin. And then you have the other set of malignancy that can originate from the thyroid component. It is going to be your thyroid lymphomas, right? So you have the follicular origin or the parafollicular origin in nature. So we'll try to understand that if a tumor is arising from the follicles, how will they going to behave? If they arise from the parafollicular cells, how are they going to behave per se? Now, when we talk about the thyroid cancers, in the follicular origin, I can divide them into two subcategories. One is going to be your well-differentiated tumor, another one is poorly differentiated tumor. The examples of the well-differentiated tumors are papillary cancer thyroid and the follicular cancer thyroid. For poorly differentiated is going to be anaplastic cancer, and one that originates from the parafollicular C cells will be called as medullary cancer. So as simple as that, right? Right. So we have differentiated the malignancies based upon its origin, whether it is originating from a thyroid follicle or whether it is originating from a parafollicular C cells. If it is originating from the follicles, we'll see whether it is a well-differentiated or poorly differentiated. The examples of well-differentiated are papillary and follicular, which are far more common. Then you have more aggressive anaplastic, and then even a relatively lesser common one, which is going to be your medullary cancer thyroid. Right? It is going to be medullary cancer thyroid. So these are the basic objectives in terms of malignancy. So our objective is to learn about all these differential tumors and talk about how are we going to counter and management when it comes across. So let's dig in. Before that, let's understand that how do we in general categorize a thyroid swelling. We've been talking about. So I can categorize the thyroid swelling into two categories. One, I can say there is a diffuse thyroid swelling. Another one is going to be a discrete thyroid swelling. One will call it as the diffuse thyroid swellings. Another one I would call it as the discrete thyroid swelling. Now, what is mean by a diffuse and a discrete thyroid swelling? In a diffuse thyroid swelling, you will notice the gland which was initially of this particular size. Let's say this is the gland which is of initially of this size. When it enlarges, you will see the entire gland is going to enlarge, not any one particular part, but the entire gland is going to enlarge completely. Such type of thyroid swellings will be called as a diffuse thyroid swellings. The best example, a swelling which was initially, this is the normal size of the swelling, and if it is transforming into this particular form, that is a diffuse enlargement of the gland, this would be called as usually goiter in nature. So when we spoke about goiter, I told you very specifically that it is a generalized enlargement of a thyroid gland where the entire gland is going to get enlarged, and then you will have a uniform swelling. A discrete thyroid swelling, for our understanding, I can further divide it into two subcategories. There are going to be two subcategories. One, we'll call it as the solitary thyroid nodule. One will call it as a solitary thyroid nodule. Another one we'll call it as the dominant thyroid nodule. Another one we'll call it as the dominant thyroid nodule. Majority of the cases that we will experience, you will notice that 70% of them, when they present to us discrete thyroid swellings, they will be solitary. 30% of them will be seen as a dominant thyroid swellings or a nodule. What is the basic difference between these two? Now, if you take this as the representation of the thyroid gland, take this as a representation of the thyroid gland, this gland will now start to form a nodule. Now, this nodule, if it is going to be only at one particular site and only one isolated nodule, this will be called as a solitary thyroid nodule. There is a single thyroid nodule that is present. On the other hand, when you talk about a dominant thyroid swelling, when you talk about a dominant thyroid nodule, you will see that it will start as a nodular swelling only. It will start as a nodular swelling. You will see multiple other nodules will also be present. Now, as there are other nodules which are present, but one nodule outsizes the rest of them. When you see in these two contexts, in a solitary thyroid nodule, there is only a single nodule. In a dominant thyroid nodule, there are multiple nodules, but the rest of the gland is not enlarged. But one nodule outsizes, or the size of the nodule which is large is quite distinctively large when compared to the other smaller ones, right? So in a solitary thyroid nodule, there is only an isolated single nodule which is here. In dominant, this nodule which is large, it outsizes the other. So the presence of, so here we say there is only a single nodule. There's only a single nodule, and here you will see the presence of multiple nodules. The presence of multiple nodules, but one nodule, there is one nodule outsizes the rest of the nodules. It outsizes the rest of the nodules. Hence the name is given as dominant thyroid swelling. Hence the name is given as the dominant thyroid swelling, right? So now we have a basic understanding that when we categorize a thyroid swelling in general, I can either call it as a diffuse or a discrete swelling. In diffuse, we have goiter-like presentation. In discrete, we have either solitary thyroid nodule or a dominant thyroid nodule. Clinically, it becomes very difficult to differentiate these two when a patient comes now, and when you try to palpate it, as you feel for the nodules which are smaller in size, you cannot appreciate, because usually if the nodule size is less than 10 millimeters, that is less than 1 centimeter nodule, it is very difficult for us to appreciate clinically. So hence, if these nodules are smaller, you will not be able to appreciate it. So what is going to happen? Clinically, it becomes very difficult to differentiate between these two. So hence, we will consider them as one single entity. So both solitary thyroid nodule and the dominant thyroid nodule will now be called as solitary thyroid nodule-like presentation. It will present to you as a solitary thyroid nodule-like presentation. It will present to us as solitary thyroid nodule-like presentation. So rather than talking about solitary or dominant, Now we have come up with a single entity where both of them can pre-exist, right? So you have a solitary thyroid nodule like presentation, right? Now, why I'm telling you in terms of malignancies, it is very easy for us to predict that which of these swellings are likely to develop into malignancy. If you look at these two subsets, diffuse swelling and discrete, obviously the probability of having malignancy in discrete is higher when compared to diffuse. Remember, a diffuse thyroid gland, when it transforms into malignancy, usually it transforms into follicular cancer thyroid, and that is your competitive exam question that has been asked in your NEET as well as INI-CET. Remember this question, I don't know why many students usually get it wrong. So when they say how would a follicular cancer thyroid presentation will come, like, yes, it will have malignant features, but usually it is associated with a long-standing untreated goiter. So there's already a goiter swelling and then it transforms into malignancy. So in general, if I summarize the whole component, remember the probability of malignancy is more in discrete thyroid swellings when compared to diffuse. But if a diffuse thyroid swelling is transforming into malignancy, it is usually going to be your follicular cancer thyroid. It is usually going to be your follicular cancer thyroid. Okay. So once you have understood this, I need to talk about a very important rule that is about predicting the malignancies, which is called as the rule of 12 in thyroid cancers, right? Now, what is this rule of 12 in thyroid cancers? In a rule of 12 for thyroid cancers, this we are going to be specifically talking about the isolated or the discrete thyroid swellings, or I can say patient who is going to have a solitary thyroid nodule-like presentation. If a patient presents a solitary thyroid nodule-like presentation. If a patient presents to you with solitary thyroid nodule-like presentation. If a patient presents to you with solitary thyroid nodule-like presentation. Now, this solitary thyroid nodule-like presentation can also be known as isolated thyroid swellings, right? So this we can address it as the isolated thyroid swelling. So this could be addressed as a isolated thyroid swelling. Now, hi Adya, I think you are also learning. I hope you are also able to understand. If you have any questions, any doubts, any queries, now post in the chat box. I'll answer it for you. All right. Guys, I'm sorry for this. My daughter is also logged in. So she is around 5 years old. And now she is trying to learn surgery from now only, right? It's an early catch-up for her also. I asked her not to log in. I don't know why, but she likes it to be on these components whenever I do a lecture. So today she'll be there on the chat box also. So please be a bit patient. I'll try to give her a bit of nudge, but we'll be there. Right. So solitary thyroid nodule-like presentation, which is also called as an isolated thyroid swelling, we follow something called as the rule of 12. Now, what is this rule of 12? It is to predict the probability of malignancy. Now, this isolated thyroid swelling can be of two varieties. It can be solid. It can be a solid swelling. It could be a cystic swelling. It could be a solid swelling and it could be a cystic swelling. There are no points for guessing that the probability of malignancy will be higher for a solid swelling when compared to a cystic swelling. So when I talk about it, the probability of malignancy in a solid swelling is going to be 24%, but the probability of a cystic swelling being malignant is going to be 12%. It is going to be 12%, right? Now, in the same context, if I split them into sex-related data, that is the probability of a solid isolated thyroid swelling. The probability of malignancy in a isolated thyroid swelling, that is a solitary thyroid nodule per se, I would say in males in comparison to that of female. Who do you think is more likely to be affected? Who do you think is more likely to be affected? See, normally the probability of malignancy is higher in females. But if you have a nodule that is present in male, that nodule being malignant is of higher incidence when compared to females. I repeat again, In general, when we say in terms of sex, who is going to be more likely to be affected in malignancy, the answer are females. But let's say you have one female and one male, both of them present with isolated thyroid, isolated nodule or a solitary thyroid nodule that is present. Now, the probability of that nodule being malignant is higher in males when compared to females. I hope you are able to understand. I repeat the sentence or this particular phrase in a very, very, weighted manner, that when we talk about malignancies, this is more common in females when compared to males. This is sorted. But imagine that you have one male and one female who has presented with solitary thyroid nodule. The probability of that nodule being malignant is higher in males when compared to females, right? So that is why we say if you have a male patient with a solitary nodule, the probability of this being malignant is as high as 48%. That means almost 50% of this will turn into malignancy. In females, it is only 12%. In the same context, when we talk about the cystic lesion, again, when you look at the data into males and females, if I isolate the data into male as well as females, the probability of malignancy of a cystic swelling in male is again 24%. In females, it is going to be 6%. So all of them are multiples of 12. So hence they are called as rule of 12. What did you learn from here? They carry a message here. If you have a male with an isolated thyroid swelling, the probability of it being malignant is higher when you see the same in females. If it is solid, it is even more higher when compared to cystic. Is that clear? Okay. यही चीज we try to explain you in our clinics also, that when you have a patient, the first thing you're looking for is sex. If it's a female, probably okay. If it's a male, it is of higher suspicion. Then you see it is solid or cystic. Cystic, it is still better, but solid, it is going to be very, very tricky, because 48% of the males with the solitary thyroid swelling are going to be malignant. Is that clear? Okay. So this is in terms of isolated thyroid swelling that you need to understand. Now, if the same subset, if I expand it to a dominant thyroid swelling, we just learned what is a dominant thyroid swelling. So in a dominant thyroid swelling, we'll do the same rule of 12 component, and again we will split them into two components, that is the solid and the cystic one. We'll split them into again two components. We have solid and we have cystic lesion. Now we talk about solid lesions. Again, as I told you, solid lesions have the higher probability of developing into malignancy when compared to cystic lesions. So you will notice that 12% of these solid lesions are going to be malignant, whereas 6% of the cystic lesions are going to be malignant. You divide the data again into males and females, right? You have a dominant thyroid swelling. The presenting patient is a male when compared to female. Again, the probability of malignancy in males are going to be higher. 24% of them is going to develop into malignancy. Only 6% of the females will develop into malignancy here. In a cystic swelling, again, when you divide them in the context of males as well as females, we divide them into the context of male as well as female, you will notice that 12% of these males will develop into malignancy. Only 3% of the females will develop into malignancy, right? If you talk about what is the probability of developing into a goiter, into a malignancy, so when you say a generalized thyroid swelling, the probability of developing for a generalized thyroid swelling, the probability of developing a malignancy, in a generalized thyroid swelling is quite less. It is approximately at 3%. Let it be solid, cystic, male, female. So we say the probability of this being malignant. So we say the probability of malignancy. The probability of malignancy is going to be 3%, right? So this summarizes, or this entire data that we have given, no, it beautifully summarizes of how you will see the thyroid malignancies, right? Now, what is the carry message for you? How do you interpret this? How do you understand this? If you have a patient who has presented to you, as we have gone from here, that either you can have a presentation of a generalized thyroid swelling or a discrete thyroid swelling. If you have a patient with a generalized thyroid swelling, let it be male, female, let it be solid cystic, the probability of malignancy in these patients are only 3%. But when you have a patient who is having a solitary thyroid or a dominant, in a solitary thyroid swelling, we'll see whether it's solid or cystic. If it is solid, the probability of malignancy is higher. It is when compared to cystic. If it is male, the probability of malignancy is higher in males when compared to females in solitary. Same valids for dominant also. In dominant, the probability of having malignancy in a solid lesion is much more higher when compared to cystic. It is more higher in males when compared to females. This is what we call it as the rule of 12. Is that clear? I hope I did make sense, because this is a concept that is very, very important for us to, imbibe per se. Now, let's say if you have a patient with solitary thyroid nodule-like presentation, we call it as the STN-like presentation, how would you approach? For a patient who is having an STN-like presentation, for a patient who's having an STN-like presentation, that is solitary thyroid nodule-like presentation. For a solitary thyroid nodule-like presentation, how are we going to move forward, right? If a patient is having an STN-like presentation, for all patients who have solitary thyroid nodule-like presentation, it is a mandate to do an ultrasound as well as FNAC. It is to mandate to do an ultrasound as well as an FNAC. That is a standard dictum that we are going to follow. Now, once you perform an FNAC, based upon what we find on FNAC, we will further decide the course of our management, right? Now, what are the possible components that you can find on an FNAC, right? So when you do an FNAC, the first probability that you can get is going to be a non-diagnostic aspirate. That is going to be a non-diagnostic aspirate, right? That means you put a needle, you're not able to get enough amount of yield, and you're not able to diagnose what a particular lesion that you have looked into. You remember in the earlier lectures, in the very beginning of it, if you look at our episode number 1 in the BLS of thyroid, you will notice that we have done something called as optimum cytology criteria. For that, I told you the needle must be of 23 gauge. You should have minimum of 2 aspirates. You should have 6 follicles per aspirate and 10 to 15 cells per aspirate to get a good yield, and that is called as an optimum cytology criteria. If you have not followed that, probably the yield is going to be poor. So whenever you have a non-diagnostic aspirate, here you have to repeat FNAC under ultrasound guidance. So when you do an USG guidance, then it is the probability of diagnosing that lesion becomes quite easy. That is if you have a non-diagnostic aspirate. The second result that you can get is going to be a benign lesion. As soon as you hear that it is a benign lesion, we need to know whether it is in a solid or a cystic form. So we will categorize this benign lesion. Either it is a cyst or it is going to be a solid component, right? You can leave if it's a 100% benign lesion, you don't need to do anything. But if it is concerned with cosmesis, the cyst can be aspirated. The cyst can be aspirated. The problem is after aspiration, if it reoccurs, what are you going to do? After you have aspirated, if this cyst is going to reoccur, what is our line of management? Now, if it is going to reoccur, I am going to aspirate again, but how many times? Remember, after reoccurrence, I am going to aspirate a total of 3 times. So it will be 3 aspirates that you can do. After 3 aspirates, if it still reoccurs, now this is an indication for surgery. This is an indication for surgery. Usually we will address it with lobectomy. Usually you will address this with lobectomy. As simple as that, right? On the other hand, if you have a patient who is having a solid swelling, right? A benign lesion but solid in component, again if it is going to be associated with cosmesis as a problem, you will see for solid lesions we only say it is going to be observed. But if it is cosmesis, you can offer for surgery, but it is going to be observing only. If it increases in size, then you are going to intervene and nothing more than that, if it is benign. Now there's something which is very tricky. You might often get something called as AUS. Now, AUS stands for atypia of unknown origin or unknown significance. It is called as the atypia. It is an atypia of unknown significance. Or it is also known as, the FLUS. Some textbooks will mention this as FLUS. What does FLUS stands for? It is follicular lesion of unknown significance. Telling it's a follicular originated, but there is no significance. It is a follicular lesion. It is a follicular lesion of unknown significance. So if you come across any of this, then currently the recommendation is to repeat FNAC again. To repeat FNAC again and recategorize it. So this is if you have atypia of unknown significance. Now what if you get a patient who says it is a follicular neoplasm? Or we say it is a follicular origin. Now when you say it's a follicular origin, my pathologist is not able to tell me whether it is a follicular carcinoma or a follicular adenoma, because FNAC cannot differentiate between a follicular adenoma and follicular carcinoma. In those contexts, what are we going to do? So my pathologist is going to tell me that because it's a follicular origin, it is better that we work up further. And when you talk about working up further, this patient has to be taken for lobectomy with frozen section. Now frozen section is on table biopsy. You will give the specimen to the pathologist, make the section in the OT theater itself, give you a report whether it is benign or malignant. If it is benign, close and come. If it is malignant, do a completion thyroidectomy, and this is what your follicular origin is going to tell you about. So this is what your follicular origin is going to be telling you about. Now, on the other hand, if you get suspicious of malignancy, the next report that you can get is probability of suspicious of malignancy. If it is going to be suspicious of malignancy. Now in thyroid, we usually don't prefer a true cut biopsy. The reason we don't prefer is because of its vascularity, tumor seeding and all that. So to avoid any of those complications, whenever there is suspicious of malignancy, you will go ahead with what we did for follicular origin. I'll take the patient for lobectomy and then do a frozen section on table and determine what to be done. So here also the answer would be that we'll do a lobectomy, we'll take the patient for a frozen section, and from the frozen section we'll see whether it's benign or malignant, and then we are going to construct it from there. The last one that you will see is obviously a determined malignancy. Now what if it is a malignant lesion? If it is a malignant lesion, then you will go ahead and perform stage-wise management. For malignancy, we'll go ahead and say that we are going to go and deal with a stage-wise management. We'll go ahead and perform a stage-wise management. We'll do a stage-wise management, right? As simple as that. So now we understood that if you have a lesion that is going to present to us in a different form, how are we going to encounter, starting all the way from a non-diagnostic aspirate to malignancy. So everything is a logical turn, no? That is how we approach it. Now to make your life difficult, they've given a name for this. This is what we call it as the Bethesda classification. Now when they say what is the Bethesda class 1, it is non-diagnostic. Class 2 is benign. Class 3 is atypia of unknown significance. Class 4 is follicular origin. Class 5 is suspicion of malignancy. And class 6, it is a malignant lesion. And this is how you learn about your Bethesda's classification. Forget about it. You think about Bethesda, you talk about, you try to memorize it. It is nothing. You have a patient, there is a lesion, you do an FNAC. Based upon that, you get certain findings. And based upon those findings, how do you basically move across? And that is what your Bethesda classification is all about. So I hope you're clear with this. Clear? Sorted? I hope everybody's clear until this point. This is the basic of thyroid cancer that we have just discussed. We spoke about how it is going to originate, how are we going to differentiate it. We spoke about the swellings that are going to be present and how they are going to present to us in a proper finding. Then we spoke about if you do an FNAC, what are the possible results and how do you encounter it. And then we spoke about something which is very, very, very important from an oncology standpoint, that is the rule of 12, to understand and predict whether the lesion that you're looking at is benign or malignant. Okay? Right. Remember, in every malignancy, no, what is the goal that you're looking for? Any idea? There's always a difference between goal and desire. If you say, when a patient comes to you with malignancy, what is your desire? My desire is to cure the patient. Make sure there is no residual malignancy. Patient lives his or her life for the rest of the time without having any problem, and you as a doctor are going to be, severely feeling proud about it, that you have done something and you have altered the course of life. But fortunately or unfortunately, I would say more of unfortunately, you cannot achieve this in most of the patients. It is being said that if a patient develops a cancer or a malignancy, right, their lifespan is cut short. It is the God's way of telling कि ठीक है, अब इस patient को ना, let's say अगर इसकी lifespan 80 years थी, कैंसर देखे ना उसको 20 या 30 साल कम कर दिया, ठीक है. अब वो पेशेंट आपके पास आया, एंड जब पेशेंट आपके पास आया, पेशेंट आपसे पूछ रहा है कि सर देखो मेरे को कैंसर हो गया, ठीक है, मेरी लाइफ स्पैन कम हो गई है, आप क्या करोगे? तो देयर टू थिंग्स दैट यू कैन से ओके एक्सेप्टेड सर, डिफिकल्ट है, ज़्यादा कुछ नहीं कर सकते. और you as a person, in fact you as a surgeon are the only person who have the ability not to alter the course completely but extend the life a bit. So basically you are shifting that period. So imagine, I'll give you a scenario where a patient comes to us with a malignant lesion, okay? And let's say if I don't operate on that patient, the patient will die probably in a year or so. And if I operate, if I'm able to extend his life another 5 or 10 years, it is my way of telling you that, okay, fine, you have been diagnosed with a terminal disease which is going to kill you in a year. Take this another 5-10 years and live your life. Do all your things that you want to do, settle everything in life that you want to do, and then go in peace. This is what you give as a surgeon to your patients. So I feel, you are the only person as a doctor. I mean, obviously we'll have other teams also, have medical oncologists, you have surgical oncologists, so the entire team per se. But what I want to put forward here is कि it's think in this way कि भगवान ने बोला कि इसकी जिंदगी बस खत्म है, और फिर आप आए, आपने बोला नहीं, रख ले 5 साल और, ठीक है. So this is what we are going to achieve in malignancies. Yes, the desire is to clean up, to give 100% cure, to make sure the patient lives his or her life to a full extent. But if you're not able to, at least थोड़ा बार्गेनिंग में ना, एटलीस्ट उस पॉइंट तक तो पहुंचो कि लो एक 5-10 साल एक्स्ट्रा दे दिए पेशेंट के लिए. यही आपको अचीव करना है. दिस इज व्हाट इज गोइंग टू बी इंपॉर्टेंट फॉर अस एज अ सर्जन, ठीक है. सो लेट्स डिग इन टू ईच इंडिविजुअल कंपोनेंट of the thyroid cancer. We'll be doing a comparative data. I'll try to analyze the 4 common varieties that we have: the papillary, follicular, anaplastic, and the medullary cancer thyroid, and we'll talk about it. Good night, Alekhya, good night, Adya. Right, I'll continue with my lecture. You guys take care. Bye. Chalo. Now, when we talk about the malignancies, so we have the 4 varieties. We have already dealt with most of the data. We'll try to reanalyze. If you have papillary cancer thyroid, it is going to originate from the thyroid follicle. Follicular cancer thyroid will also originate from the thyroid follicle. Anaplastic will also originate from the thyroid follicle. Medullary cancer thyroid will originate from the parafollicular C cells. So based upon the origin, you will be able to differentiate that these 3 malignancies are follicular and medullary cancer thyroid is going to originate from the C cells. Now, by incidence, you can see the most common thyroid cancer, the most common thyroid carcinoma overall. The most common thyroid cancer overall is going to be your papillary cancer thyroid. The next one is your follicular, of course, then you have anaplastic, then you have medullary, and the thyroid lymphoma is also 2.5% only. So basically the thyroid lymphomas and medullary cancer thyroid have equal amount of incidence. When we talk about follicular cancer thyroid, the follicular cancer thyroid is the most common, it is the most common thyroid cancer in ectopic thyroid gland. In the ectopic thyroid gland. It is the most common thyroid cancer in an ectopic thyroid gland. When it comes down to anaplastic cancer, remember, because of its aggressive growth potential, this is associated with worst prognosis. This is associated with the worst prognosis, and medullary cancer thyroid will be associated with a disorder that we'll talk about, is going to be your multiple endocrine neoplasia 2. So it is associated with MEN2 syndrome, that is a multiple endocrine neoplasia 2. When we talk about malignancies, usually we say the age of presentation is going to be on the elder side. That means now earlier we used to say above 5th decade of life. Now the research shift in the age presentation is in the 4th decade of life. But the papillary cancer thyroid is seen at a relatively younger age group, that is at around the 3rd decade of life, that is around 30 years. Your follicular cancer thyroid is seen in age above 40 years. Your anaplastic is seen in age above 50 years. Whereas your medullary cancer thyroid, if it is sporadic, that means it is a general population, it will be seen in age above 50 years. But if it is associated with MEN syndrome, it will be seen in age under 20 years. Right? So associated MEN syndrome, you have a very early age of presentation. Otherwise, you'll see in age about 50 years, right? All these malignancies, irrespective of if, but, this, that, are more common in females when compared to males. So let it be papillary, follicular, your anaplastic or medullary. All these malignancies are more common in females when compared to males. Now, there are certain specific genes which are important. The genes which are commonly associated with papillary cancer thyroid is going to be BRAF mutation, PTC1 and PTC2. For your follicular, it is going to be PTEN gene mutation, also associated in a Cowden's disease. The BAX mutation, there is no specific mutation for anaplastic, but RET gene mutation is a significant mutation that you will see in your medullary cancer thyroid. Most of them do not have a specific risk factor. The two important risk factors that we can talk about is going to be in terms of medullary cancer, in terms of papillary cancer and follicular cancer thyroid. For your papillary cancer thyroid, number one is the history of ionizing radiation. History of exposure to an ionizing radiation. Now, it is an important thing to understand that this radiation exposure should have occurred at the age of 5 and less. So if a patient has an exposure of ionizing radiation in age below 5 years, the probability of developing that into a papillary cancer thyroid is very high. I'll tell you a very classical example. A patient who had an Hodgkin's lymphoma would have undergone a radiotherapy, and post radiotherapy in her mid-20s, the patient would develop papillary cancer thyroid. This was this year's NEET PG question as well. I mean, the similar question was asked that if you have a patient's presentation, there's a Hodgkin's lymphoma is there, and then patient developed thyroid swelling, what is the most likely diagnosis? There the objective is the patient would have received a radiotherapy to the neck, and later on that radiotherapy which has been provided with ionizing radiation has now developed into your thyroid cancer. So it is your ionizing radiation. Another one, if presence of history of thyroglossal duct cyst. History of thyroglossal duct cyst, specifically if it is untreated. These are the two important risk factors that can traverse or they can present to you in terms of papillary cancer thyroid. For a follicular cancer thyroid, it is long-standing. It is a long-standing untreated goiter. It is a long-standing untreated goiter. There is no specific risk factor for anaplastic as well as medullary cancer thyroid. As simple as that. Okay. So this is the first set of comparative data that you have to analyze to get you an objective that what we are talking about in terms of papillary cancer thyroid, in terms of follicular, anaplastic as well as medullary cancer thyroid. Now let's talk about how will they present to us clinically. So clinical features of each individual component, and how are they going to present to us. So when you talk about the papillary cancer thyroid, now few important things about the papillary cancer thyroid, they are slow growing. Now because they are slow growing, they are also called as the occult thyroid cancers. They're also called as the occult thyroid cancer. That means they're hidden. Why they're called as hidden? Because by the time they become evident, no, they would already caused the lymphatic metastasis as well. So the slow growing lesion, it is a slow growing lesion that you will encounter. Now these slow growing lesions, now if you present to you, they'll present to you as solitary thyroid nodule like presentation. They'll present to you as solitary thyroid nodule like presentation. They will present to you as a solitary thyroid nodule like presentation. Along with solitary thyroid nodule like presentation, they can also present to you with cervical lymphadenopathy. They can present to you with cervical lymphadenopathy. That means an enlarged lymph nodes. They can present to you as a cervical lymphadenopathy, that is an enlarged lymph nodes that can be present. So these can be slow growing, they can be solitary thyroid nodule like presentation. They have a cervical lymphadenopathy as well. This is a special scenario that you can see, that these patients can also present to you with something called as a lateral aberrant thyroid. Now what is this lateral aberrant thyroid? Now this is a condition. This is a condition where a patient is going to present to you with a swelling on the lateral side of the neck. Okay. Now, I'll just show you an image of my patient. Okay, after this I'll show it to you. In a lateral aberrant thyroid patient, no, I'll give you an example. Let's say a patient is presented with swelling in the lateral side of the neck. There's no swelling in the midline of the neck. We did an FNA and we found there is presence of thyroid tissue. What is your diagnosis? Are you thinking it is going to be an ectopic or a non-ectopic thyroid gland? That is the only thing that I have to determine. You cannot think it to be an ectopic thyroid gland, because the concept of ectopicity is it might not be present at its normal embryonic location, but it will always follow your normal embryonic path, which is the midline. So lateral side of the neck will not have that presentation. So if you have a thyroid tissue which is present on the lateral side of the neck, how did it go from here to here? The only way a tissue can migrate from one place to another is going to be because of metastasis. And the lateral aberrant thyroid is basically a cervical metastasis. It is a cervical metastasis from papillary cancer thyroid. From papillary cancer thyroid without thyroid swelling, without any evidence of, or we can say without the evidence of thyroid swelling. This is what we call it as lateral aberrant thyroid. So this is how a patient of your papillary cancer thyroid can present to you. When it comes down to the follicular cancer thyroid, a patient of follicular cancer thyroid is going to present to you as goiter like presentation. They're going to present to you with goiter like presentation. Along with goiter like presentation, you will see it will be rapidly increasing in size. It will now start to increase in size rapidly. So it's a fast growing, it will rapidly increase in size. It is going to be hard and nodular surfaced. So it is going to be hard as well as nodular, and more importantly, it will be associated with your hematogenous spread. It spreads via blood, usually goes to the flat bones, specifically onto your forehead bones. So when this goes onto the flat bones, they will present to you as a pulsatile forehead bony swelling. This is going to present to you as a pulsatile forehead bony swelling. So when I say a pulsatile forehead bony swelling, when you say pulsatile forehead bony swelling, it is because of osteolytic secondaries to flat bones. So the easy pickup point for a follicular cancer thyroid is you have a swelling which is goiter-like, and then you have a swelling in the forehead which is pulsatile. You now know you're probably dealing with follicular cancer thyroid. Anaplastic cancer, on the other hand, because it's an aggressive tumor, it is going to present to you with huge midline neck swelling. It is going to present to you with huge midline neck swelling. Now this huge midline neck swelling, it is going to be rapidly increasing in size. This will be rapidly increasing in size. It will share its architecture to the follicular by saying that it is hard and nodular surfaced. But more importantly, it is associated with local infiltration. Because it causes local infiltration, it is now going to involve underlying structures, compress them, as well as local infiltration. Underlying structures which are going to be trachea, esophagus, recurrent-laryngeal nerve, and hence developing as pressure symptoms. Along with pressure symptoms, it is now going to cause infiltration of the carotid sheath. Infiltration of the carotid sheath will result to you as Berry sign positive. We have discussed it before. Berry sign positive is an impalpable carotid pulse at its normal location because either the gland has become too large, push the carotid vessel behind the sternocleidomastoid muscle, or there's a malignant infiltration, as it is happening in the case of our papillary cancer thyroid. So the huge midline neck swelling, rapidly increasing in size, hard and nodular, associated pressure symptoms are Berry sign positive, and because it can cause local infiltration, it can infiltrate the sternocleidomastoid muscles, restricting the mobility of the neck. And if the neck mobility is restricted, it is going to be presented to us as frozen neck. This will present to you as frozen neck. So this is going to be with respect to your anaplastic carcinoma. In a medullary cancer thyroid, it is going to present to you as solitary thyroid nodule-like presentation. It is going to present to you a solitary thyroid nodule-like presentation that we have already discussed. Right? Now, along with that, you need to understand that the medullary cancer thyroid has the ability to secrete a compound that is called as 5-HT3, that is serotonin. Now, as the secretion of serotonin will increase, the effect of the serotonin on GI mucosa is going to increase the GI secretions. Hence, it will result in secretory diarrhea. It will be associated with secretory diarrhea. So, it will present to you a solitary thyroid swelling. It will present to you a solitary thyroid swelling associated with diarrhea. Now, because these are also known to spread via lymphatics, they can also be associated with cervical lymphadenopathy. They can also be associated with cervical lymphadenopathy. And more importantly, it can also be associated with bony secondaries. But here it will cause an osteoblastic bony secondaries. So your follicular cancer thyroid is associated with osteolytic secondaries. Whereas your medullary cancer thyroid, it is associated with your osteoblastic secondaries. Okay? Now, I have given you in a quick succession about all these symptoms, but how do you pick up when you're doing your clinical examination? Now, pick-up points are very important. Papillary cancer thyroid will be slow growing. It will present to you as solitary lesion, and it has the ability to present as lateral aberrant thyroid. 3 points I have to remember. Follicular cancer thyroid, it will have goiter with pulsatile forehead bony swelling. You know you're looking at follicular cancer thyroid. Anaplastic, you'll see huge, rapidly increasing in size, hard pressure symptoms, Berry sign positive, frozen neck. So any of these words in combination will tell it is anaplastic. If it is a solitary thyroid nodule-like presentation with diarrhea, it is your medullary cancer thyroid. Okay? Hi Gumpy Pro 007. Thank you. I'm good. Currently teaching. तो इधर concentrate करते हैं. ठीक है? So this is how you will see the presentation. Okay? Now once you have these patients, see mota kya hai? All these patients are presented with thyroid swelling. Okay? So what are we going to do? You need to analyze that how these malignancies are going to spread, what is the most common site for metastasis, and how are we going to investigate. Now when we talk about the mode of spread, the papillary cancer thyroid usually spreads via lymphatics. It is going to spread via lymphatics. Follicular cancer thyroid is going to be hematogenous. Anaplastic, it is going to have a direct infiltration. This medullary cancer thyroid will have a combination of both lymphatics as well as hematogenous. Lymphatic as well as hematogenous. The most common site for secondaries for this is going to be lungs. These are going to be bones, and especially your flat bones. It is going to be flat bones. This direct, again, it goes to lungs. Here it usually goes down to liver, if not to bones. Now, as we all know, in your medullary cancer thyroid, they will form osteolytic secondaries. They will form an osteolytic secondary. The bone becomes quite brittle. It becomes weak. It is easy to break. So the common pathological fractures will be seen in this. Whereas in medullary cancer thyroid, it is associated with osteoblastic secondaries. Right? Now, how do you remember it? We keep confusing. Now, kaun sa lytic hai, kaun sa blastic hai? It's very simple. Master blaster. Master Sachin Tendulkar, right? Master is medullary, blaster is blastic. So master blaster, medullary is blastic. Follicular will become lytic. Okay? Follicular is like fall. Fall is to break. Break is lytic. Okay? Follicular is lytic. Master blaster, it is going to be medullary, is going to be blastic secondaries. Right? Now, whenever a patient comes to you with any of these thyroid lesions, we have a standard protocol which we have already did. We will do a thyroid function test. We will do an ultrasound because this is where majority of the things will get cleared up, and then we will do an FNAC to look for the same components. So here also thyroid function test, ultrasound, FNAC, thyroid function test, ultrasound, FNAC, thyroid function test, ultrasound, FNAC. Now this is going to yield us a diagnosis. Now based upon that, we are going to move forward. But here is the point. When you do an FNAC, in your follicular cancer thyroid, according to your Thai classification, you remember the Thai classification? Can anybody tell me, if you have a follicular origin lesion, according to the Thai classification, what will be your category? Quick feedback. If you have done the optimum cytology, we have already discussed it. On a Thai classification, what is going to be the categorization? Anybody? Quick feedback. We have follicular origin. It is your Thai 3. Same, if you go down there, we have Bethesda class 4. Both of them means the same. No, that follicular origin. Now, why I'm telling you this is FNAC cannot differentiate. Remember, FNAC cannot differentiate between follicular adenoma, between the follicular adenoma and follicular carcinoma, It cannot differentiate between a follicular adenoma and a follicular carcinoma, right? The only way that you can differentiate the follicular adenoma from a follicular carcinoma is by two categorization. You have to look for something called as the capsular breach. You have to find for something called as the capsular breach and then look for the vascular breach as well. You have to look for a capsular breach as well as the vascular breach. In follicular adenoma, there won't be any capsular or vascular breach. In follicular carcinoma, it is associated with the capsular as well as vascular breach. So the only way you can differentiate a follicular adenoma from a follicular carcinoma is by assessing whether it has a capsular and a vascular breach present or not. If there is presence of capsular and vascular breach, it is going to be malignancy. If there is absence of capsular or vascular breach, it will remain as benign lesion. As simple as that. Okay? On a histopathology, what are the findings that you're going to look across? Now, in a papillary cancer thyroid, you see these empty vacuolated cells. I hope everybody knows it. These empty vacuolated cells are what we call it as the orphan Anii nuclei. So see, these empty vacuolated cells are what we call it as the orphan Anii nuclei. Apart from the orphan Anii nuclei, you will see another finding in the papillary cancer thyroid. This is what you see, this concentric circles like onion peel appearance. This is what we call it as the Samoma bodies. These are what we call it as the Samoma bodies. Samoma bodies, as you can see here, these are these concentric circles. This is how the Samoma bodies will present to you. Now, what is Samoma body? Samoma body is an example of a dystrophic calcification. This is an example of a dystrophic calcification. This is an example of a dystrophic calcification. So what are the sites where you will see this dystrophic calcification? Samoma bodies. Now the sites where you can see Samoma bodies can be remembered by your favorite subject, that is your PSM, right? P stands for what? It stands for the papillary variant, that is of papillary variant of thyroid carcinoma or papillary variant of renal cell carcinoma. Both of them will have samoma bodies. S stands for serous cyst adenoma of ovaries. It is the serous cyst adenoma of ovaries. It is the serous cyst adenoma of ovaries. M stands for meningioma. Right? So you have the papillary variant of thyroid cancer and RCC, serous adenoma of ovaries. Meningiomas are the sites where you will see presence of samoma bodies. Another important thing that you will see in a histopathology is in the medullary cancer thyroid. You can see these strands of tissue that is going to be growing inside, and these are what we call it as the amyloid in stroma. Presence of amyloid in the stroma of the tissue indicates of medullary cancer thyroid. It is going to be in medullary cancer thyroid. Leiomyoma is not that characteristic, so I'm going to skip that. The standard ones are going to be the papillary variant of RCC as well as your thyroid cancer, serous adenoma of ovaries, and then you have meningiomas. Okay? Chalo. So this is with respect to the histopathological findings, and this gives you the diagnostic criteria that you are looking at the following components. In the medullary cancer thyroid, you can have a variant which is called as the Hurthal cell carcinoma. Now, Hurthal cell cancer is basically an aggressive variant. It is an aggressive variant of follicular cancer thyroid. It has got an excessive amount of oxyphilic cells, or also called as the Ashkenazi cells, and this is associated with poor prognosis. This is associated with poor prognosis, right? So this is how we are going to diagnose our patients of thyroid cancer. So we came up with the entire workup, that what is the classification, how do you categorize this, how do you see the presentation, how do you differentiate from one from the another, and with all this into consideration, you have now come to a conclusive diagnosis. Now we have a working diagnosis of papillary cancer thyroid, follicular, whether it is an anaplastic or medullary. Based upon that, we'll go with staging. Based upon the staging, we'll look for management. After the management, look for the post-operative workup. And after the post-operative workup, we'll talk about lifelong management. Okay? So this is how we are going to deal with it. So for today, this is where we end. We have now diagnosed the malignancies. Stay tuned for tomorrow, where we'll talk about the management of thyroid cancers. So with that, signing off. Thank you so much. If you have any questions, any queries, you know where to reach out. Anytime, any questions, any queries. If you want to reach out, you know where to get it. You can log into our Instagram channel. That is going to be the surgery guy. It is by my name, which is Dr. Sandeep Seeram Reddy. So look up for this. Any questions, any queries, you can post it directly, DM it to me on the Insta or on the Telegram group. With that, thank you so much. Good night. Take care. See you tomorrow. Stay tuned for the management of thyroid cancers. Bye-bye. Any questions, any queries? I just see. Thank you, Mahek. Thank you, Rahul. Thank you, Mansoor. You guys have been consistent, yeah? It's good. We'll build up the series as big as possible. Tomorrow, extra class nahi beta. Kal bataya tha na grand session. So whenever we do a Thursday, it will be a grand session. So kal hamara last episode hoga season 1 ka, that is going to be your thyroid. तो कल हम अपना थायराइड खत्म कर देंगे. तो उसके बाद आपको जब भी थायराइड के बारे में कुछ भी जानना, विल कीप एडिंग स्मॉल क्लिनिकल वीडियोस विंगेट जो मिलता रहेगा, इसी सीरीज में ऐड करते चले जाएंगे. तो जब भी आपको टाइम मिलेगा, आप वो क्लिनिकल सीरीज देख लेना, थोड़ा क्लिनिकल एग्जामिनेशन देख लेना, तो ऐसे करके ना सीरीज को मैच्योर कर लेंगे, सो दैट व्हेनेवर लाइफ में कभी भी आगे जाके बिना इवन यू बिकम अ सर्जरी रेसिडेंट, दीज लेक्चर्स आर स्टिल गोइंग टू बी वेरी वेरी रेलेवेंट. These are going to help you no matter in whichever field or whichever stream that you take in. Yes, if you become a surgeon, nothing like it. It's gonna be a gold mine for you guys, right? So with that, thank you so much. Signing off. Take care. Goodbye. See ya.